Well, I want to thank everybody for having me for these couple of days. And it was an adventure getting here, but it's so nice to be here. And your residents have done just a fabulous job. They're just so fun to work with and have really done a nice job on the cases. So I wanted to talk about women with dense breast tissue and sort of how to manage them, because this has been a big sort of cultural change, really, in the United States. And so it'll be interesting to see how and if and when that plays out here in Canada. So I need to first disclose that I have some financial interests with Hologic and Volpara. Both of these companies make automated density software, so I help them with their research and things. So that's that. Okay, so what we're going to do, we're going to talk about the implications of breast density as a limitation of our ability to detect cancer and as a risk factor for breast cancer. We'll talk about where that risk plays into other risk factors, like where that is on the relative scale. And then we'll talk about screening these women. What are our limitations? What are our alternatives? What might we be looking at in the future? Okay, so this is sort of going to be our outline for the talk. So I'm going to start by just talking about the political landscape. So Nancy Capello is a PhD woman. She lived in Connecticut. And she was having her mammograms every year, good soldier there. And then relatively recently, after a normal mammogram, 6 weeks later, her physician feels a lump in her breast, sends her for a mammogram, ultrasound. It pops up on the ultrasound, obvious cancer. She ends up having a more advanced cancer. It was not a stage 1 or 2, I believe it was a stage 3 cancer. And so she got very upset because she's thinking, I've been a good person, I've been getting my mammograms every year, and why do I have advanced breast cancer now? So she was very upset. So she calls these sort of the happy grams, sort of, you know, I should be happy, I have a normal mammogram, how can I possibly have cancer? And as we all know who read mammograms, mammography is limited in its detection and sensitivity for cancers in women with dense breast tissue. We know, the referring physicians know, but women don't really know as well. And so I believe at least still some women are oversold on this idea of mammography finding all cancers. I'm getting my mammograms, therefore I should not ever die of breast cancer. So we've sort of oversold that. And so Nancy went on to found this group, Are You Dense? Yes. So this is really sort of a women's advocacy group that is trying to help educate women about the issue of breast density, both as a masking and as a risk factor. And if you look at this sort of more closely, there's a lot of issues here. I think this tells it all. Exposing the best kept secret. You know, if we go back to Nancy's story, she says, my radiologist knew, my doctor knew, but me, the woman with the actual breasts and the now breast cancer, didn't know. And so her whole idea is we need to let women know about breast density. If you go and search around on their website, you'll see sort of these testimonials. So I think there's sort of a lot of trust that these women have. I hope you can kind of read that. It's a little hard to read on this. But basically, my density limited the sensitivity of mammography, but no one ever informed me. My radiologist knows, but you are never informed. So really what they're advocating is that communication of density to the women who are having mammograms, that they should know that there's limited sensitivity. So these women have gone all over the country and advocated for these density laws. So Virginia was the third state in the United States to have one of these density laws. So our legislature, initially we got it to be pretty soft. So our initial thing in our FDA letter that we have to send to all of our patients, it had, if they were heterogeneous or dense, we had to add this statement. Your mammogram demonstrates that you may have dense tissue which can hide cancers or other abnormalities. There's nothing here, boy, you should get an MRI or a screening ultrasound. It's very soft. Now, this woman came back to our state legislature. This is a woman who's had breast cancer with a false negative mammogram with advanced cancer. And she's there talking to the legislatures. Who do you think your legislature is going to go with? like they're going with her, right? But I don't want to like have to tell all my patients. They're not going to listen to the radiologist. Are you crazy? So these bills have been very well received by legislative bodies, let's say. So our Virginia legislature, they came back and wanted a more strict law. So now our current law, the main thing that you want to see here is it's given to you to raise your awareness. Go talk to your doctor. At that time, ask your doctor if more screening tests might be useful based on your risk, i.e. ultrasound, MRI. So ask for more testing. Now, at the time of Nancy Capello's, all of this stuff going on, we had really no evidence about screening ultrasound. It was before the results of the Akron 6 screening trial were published. And we still don't have good information on using MRI for women with dense breast tissue alone as a risk factor. So, Nancy, I can understand, was upset. These women are upset, but really mammography was what we had for screening at that time. So that's a reasonable thing. But we need to think about this moving forward. Okay, so currently there are 19 states with density laws in the US. And you can see from 2012 to 2014, there's a lot more. Now the ones that have these little stars mean that in that legislative body, you also have to pay for screening tests. So insurance must cover screening tests. So that's only 4 of those states. But Connecticut, that first state, already had a pre-existing law. So when they passed this mammography dense law, they could do all the screening ultrasounds, even screening MRI, if it was requested by the ordering physician. So in Virginia, that's not going to happen. So in Virginia, if they want additional tests, they have to pay out of pocket if they have just dense breast tissue. Now there is actually a bill that's been proposed in the federal legislature. Basically what they want to do is sort of consolidate all these state laws into a more uniform message to women. I don't know if this will pass. I know this was submitted in July. I don't think it's passed yet, but previously other proposals have been submitted and not passed. So we'll see. But this is not going away. Remember, this is all grassroots. So this is the women advocating for this. So I understand it's not happening here, but it could totally happen here. So it just depends on how that communication happens. So these women may be in a legislature near you soon. Okay, so that's sort of our political landscape. Women are asking for more tests and more knowledge. So now, what does it mean to us, breast density and mammography? So, a story's always good, right? This is one of the wife of a good friend of mine who's a physician. She also comes every year for her mammogram. She's been recalled a few times, spot this, spot that, scan that. She's very dense, and now she's got a lump in her left breast. Well, I wish you could see it better. So her mammogram's normal, but she's got sort of a little small hypoechoic mass there, maybe a centimeter or so on ultrasound. And on her MRI, though, she's got multifocal invasive ductal carcinoma, about 5 or 6 centimeters. So she's got a lot of disease that I cannot see on the mammogram to save my soul. I mean, her mammogram's just normal, but she's dense. And I think this unfortunately happens more often than we'd really like to acknowledge as imagers. Yeah, I can find her cancer now that it's palpable, but how much does that really help her long-term outcome? So the problem with mammography really is that masking effect. So the sensitivity of mammography is decreased in women with very dense tissue. So that's been shown in many studies, really. Now, interesting, this study by Carla Kurlikowski with the Breast Cancer Surveillance Consortium actually found that there was not a decline in sensitivity for women with very dense tissue when you were using digital mammography. However, I have not seen that reproduced in other studies, so I don't know. My experience is I miss a lot of stuff in very dense tissue. Specificity is also a problem. Women with denser tissue are going to have more recalls. We know that both from film screen and from digital mammography. That didn't really change with the advent of digital. So if you have a place where you have film screen and digital, and you have a woman with dense tissue, we know that digital mammography performs better. If you have a woman with dense tissue, you need to put her on the digital. The fatty replaced woman, doesn't matter whether you do film screen or digital. But dense really should be moved on to the digital machine if you have both systems. All right, so we know the limitations of mammography with dense tissue. All right, well, what about that as a risk factor? Does this increase their risk? Well, yes, very much so, unfortunately. So John Wolfe at Michigan was the first person to describe this association of breast cancer and breast density. Now, who remembers the Wolfe patterns? Okay, you don't have to raise your hands because this was a while ago, but you've probably at least heard of them. So John described this N1, P1, P2, DY, and they were descriptive, but they were loosely based on density. Now, in my mind, I'm like, well, those both look fatty to me, and these both look pretty dense. So what's the difference between these? I'm not sure I could reproduce these. But he did find a relative risk of 37-fold increased risk for the women that had these two density patterns compared to these. Now, nobody's ever reproduced 37-fold increased risk. That's really, really high. But the other issue with John Wolfe's patterns was that other people had a hard time replicating them. So the reproducibility when other radiologists tried to use his N1, P1, whatever, was very bad. It was not very reproducible. So either he really knew what he was doing as far as who was at risk or something, but nobody's been able to reproduce that. There was a lot of criticism about density for that reason. But other people sort of went on and tried to make it a more reproducible pattern. So now people moved on from there to look at mammograms and forget like the descriptive part. What is the percent of breast, the whole breast, that has breast tissue in it? So Norman Boyd, actually just in Toronto, started this Boyd classification. So basically no breast tissue, less than 10 to 25%. So basically a visual estimate of the amount of breast tissue that somebody had. And what he found in his studies was that there was about a 5-fold increased risk for women that were very dense compared to women that were fatty replaced. That's a pretty big number, 5-fold increased risk. That's a lot. Now, other people then went on, like Martin Yaffe, also at Toronto, to develop computer-assisted programs that you would basically do computer-based segmentation of the mammogram to say, okay, this mammogram is 37% dense, or this one is 12% dense. So a more reproducible way to measure breast density. And then now there are automated ways where you use the raw digital mammogram file. It gets sent through a computer program, and it estimates the volume of breast tissue. So instead of an area, like a 2D, you're estimating sort of how white is that breast tissue, so that you're actually getting a volume of breast tissue. So there are automated programs available now. All right, so these are all the studies that have been done relating breast density and breast cancer risk. Don't worry, we're not going to go through each one of these because there's a long list. So, but you can see these early studies were like case control studies, then nested in a cohort. And if you look at sort of where they're done, they've really been done all over the world. Most of these are US and Canadian, but this is the Dutch screening program. This is from Japan. So they have been done in other places in the world as well. Lots of women, so thousands of women have been studied with this. And what these studies have shown, this is the same list of studies. If you look at the odds ratio, and we just sort of look down this column, the average is about 4. So women, this is comparing the very dense to the fatty. So women with very dense tissue are about 4-fold increased risk for developing breast cancer compared to women that are fatty replaced. Now, if we're going to use, if we want to see if it's statistically significant, what we need to do is look at the left number on the 95% confidence intervals. If it drops below 1, then it's not statistically significant. Do you see any that are less than 1? Okay, that one right there. That's the only one. This is a sub-study of a Japanese study. This was a small number of women who were premenopausal and very dense in that study. So there's a lot of noise there. But otherwise, all of these are statistically significant. So if you hear people say, well, it's controversial if there's a relationship of density and breast cancer risk, I'm not hiding any studies, I promise. I'm telling you every study that's out there. It is not controversial. It is a very solid evidence that there's a clear association of density and breast cancer risk. One more study, just 1 million or so mammograms, just in case you still don't believe me. This is from the Breast Cancer Surveillance Consortium again. Again, about a 4-fold increased risk. This one was not adjusted for BMI, which you really have to do to get an accurate reading of density. But still lots of evidence to show that this is associated with breast cancer risk. Okay, so how do I put that into context? Well, does everybody in here know their serum cholesterol level? Okay, you young guys probably don't. But everybody over the age of 40, I'll bet you know your serum cholesterol level, right? Am I right? Yes. Okay. Why? Because that predicts your risk of cardiovascular death, right? Okay. So this is a graph. This is cholesterol and the risk of cardiovascular death, okay? So everybody wants their number to be less than 200, right? That's good. Because to lower your risk. This is BI-RADS density and your risk of breast cancer. Not breast cancer death, okay? That's different. But breast cancer incidence. Density is an important risk factor. We can't ignore it. We gotta pay attention here and figure out what's going on in these breasts. So, we are doing lots of studies to try to figure out what is it about that tissue, because something is there that either is helping to initiate these cancers or helping them grow. So I'm working with some of my basic scientists to sort of figure some of these things out. But anyway, cholesterol, let's go back to that. Okay, a lot of people know their cholesterol level, but I bet you also know your HDL and your LDL and your triglycerides, right? So cholesterol alone is important, but it's really a lot more complicated than that, isn't it, as far as your cardiovascular risk. And some people have a very high cholesterol level and really their arteries are clean as a whistle. So there's other stuff that plays into this. So density like that is probably a lot more complicated than we realize. Is it the women that have sort of the clumpy tissue that are more at risk than the women with, what I call the cirrus clouds, the little fluffy breast tissue? So there's probably more important things going on there. We really need to figure that out, though. So it's probably more complex than we know. All right, where does density play in with regular breast cancer risk factors? It's a pretty significant risk factor. So, if you're a woman and you show up for your mammogram, they ask you a list of questions like, well, when did you start your menses? When did you go through menopause? How many children have you had, etc. Those really very minimally influence our risk of getting breast cancer. And women who take menopausal hormone therapy are about 30 to 40% increased risk for developing breast cancer. Women with dense tissue, 4 times more likely. That's way more important. So the things that we really thought were more important risk factors are really minor. So dense tissue is important, not as much as biopsy with atypia or prior history, and also women that may be at genetic risk. So BRCA carriers, they're way, way high risk. But that's a different category. All right, so I like to look at breast cancer risk factors in sort of 3 categories. So the personal risk factors, the ones we just talked about, those are hormonally based, but minor risk factors, 30, 40% increase in risk. And obesity is in there as well. And then that sort of column of breast disease, LCIS, ALH, some people put DCIS in there, ADH, that's a more moderate risk factor. And I also put breast density and breast radiation in there as well. And then there's genetic risk. Women who have a genetic mutation that predisposes them. Women with a strong family history may be somewhere into the minimally increased risk, moderate, or strong family history, depending on the degree of relatives, the age at onset, and that sort of thing. So family history is in there as well. All right, so how do I put that into perspective now? How do you put all of those into, well, what does that mean for a woman? So what is the average woman on the street's lifetime risk of breast cancer?
1 in 8.
1 in 8, okay. And I can do math, that's 12.5%. So average woman lifetime risk is 12.5%. Okay, so average risk, we would consider somebody to be a less than 15% lifetime risk. Women are considered high risk if they have a lifetime risk of greater than 20 or 25%, depending on where you want to draw that line. This is sort of that moderate risk. They're not really high risk. They're above average risk though. This is where density falls. So who are the women who are really high risk? Well, those are mainly the genetic carriers. So women who have those genetic mutations, that's really most of those women. Also women who had a radiation to the chest at a young age, usually for Hodgkin's, they're also considered at high risk. Now what are the moderate risk factors? That would be dense tissue, biopsies with abnormal findings, intermediate family history, prior breast cancer. Now, you can combine some of these though and put the women up in here. So let's say that a woman had some family history of breast cancer, a sister with breast cancer, let's say, and a biopsy showing LCIS. Those two factors would be enough to put her into the high risk category. And the way that we do that is by using risk models. So you can combine these sort of combination of risk factors to also bump them up into the high risk category. We use risk models to assess that. The left is sort of the Gale model, easy to use, bad on accuracy. The Gale model was developed before the BRCA mutations were even known. And this is the Tyrer-Cuzick model. So the Tyrer-Cuzick model is much more comprehensive. You can see it has a pedigree and things. It's better, but still not terribly accurate. We have actually worked on developing a risk model at UVA that incorporates breast density, because the problem with Gale and Tyrer-Cuzick and pretty much all the other models is they don't include breast density. So here we have this at least a moderate risk factor, and nobody's put it into even risk analysis for the patient. So we've developed this model. We're going to present it at the San Antonio Breast Cancer Conference in December, and it functions much better than Tyrer-Cuzick or any of our current models. So hopefully that will be out. It'll take a while because we'll have to do secondary validation. Okay, so we've talked about breast density as a risk factor. Now, what about tailoring breast cancer screening? So how might we change what we do based on the density? And really, we need to start taking into account risk if we can have a model that accurately produces risk. So this is what we do currently, right? Everybody, well, this is at the US. Everybody in the US, 40 and older, mammogram every year. Done, unless you're high risk. Then we do more stuff. But unless you're high risk, this is what you're going to get every year beginning at age 40. So we're really using a one-size-fits-all approach to screening based on sex and age. So pretty minimal criteria for establishing screening. We really can do better than that. But before we talk about alternatives, I think it's really important to acknowledge that mammography works. So this is the breast cancer mortality in the United States over the last since 1975 to 2010, so 35 years. So that's, you can see breast cancer mortality has declined by about 30% since the early 90s when breast cancer screening really became prominent. So 30%, that's a lot. And most of that is due to mammography, at least 2/3 of that. About a third is thought to be due to better treatments like tamoxifen and other drugs. But that's really not great, right? 30%, that's good, really good. You know, have you ever thought about why is mammography so controversial? Like, why is it in the New York Times, like every month? There's a new article about, boy, it doesn't function that well, and there's false positives. Well, if you look at the randomized screening control trials, and even the service-based screening, using mammography declines mortality by 30 to 40%. I don't think mammography would be as controversial. It was 50, 60%, 70% reduction in mortality. Then people would stop bothering us. There wouldn't be these articles. So I think what this tells us is that mammography works, but there's room to do better. So I think we really need to think about how we're screening and if we can tailor our screening to give our resources to the women who need it more, back off on the women who don't need it as much. So that's what we're going to talk about. So what our alternatives might be. Well, these are sort of some of the alternatives that people have discussed. is MRI, Tomo, ultrasound, and I'm going to talk a little bit about contrast-enhanced mammography. This is very new. We're just starting to do it. Okay, so MRI. MRI works great for women who are very high risk. It finds a lot more breast cancers, 3 cancers per 100, so 30 cancers per 1,000 compared to 5 or so by mammography. So MRI is clearly the most sensitive test we have for breast cancer. But what are the downsides? I mean, it's really expensive, right? It's a very expensive test. To apply to all the women with dense tissue, I mean, that would bankrupt our system. So we can't really afford to do that. The only way that breast MRI is cost effective is when you use it for the mutation carriers. That's the only place where the cost per quality adjusted life year drops below $100,000, which is about our threshold for doing any test, really. Okay, so for the very high risk women, we're going to do MRI. And I don't really care if they're dense or fatty, they're getting MRI. So we can just forget about them. Very high risk, we're done. We don't need to worry about them. It's really these women that are at that moderate risk. What are we going to do with them? Well, what does the American Cancer Society say about screening MRI? It says, well, first, we don't know. You could try to use it, but we have no evidence for it. And there's really still no studies to help guide us as far as how often are they going to find cancers on MRI for women who have dense tissue but no other risk factors. There are some studies. I know there's one study opening in Nijmegen in the Netherlands just for this purpose, doing MRI for women with dense tissue and no other risk factors. So we'll see how that plays out, but that's going to take a while. Obviously, it's really expensive. All right, so what are we left with? Tomosynthesis and screening ultrasound. Okay, so let's talk about tomosynthesis. So tomosynthesis, this is a Tomo machine. It looks exactly like a regular mammography machine. The only difference is that tube head is going to swing over while they're taking the exposure. So it's going to look like this. Basically, if this is the breast in compression, here's our compression paddle, here's our image receptor. We're going to acquire 15 low-dose X-ray pictures. And then those are going to be reformatted into little slices through the breast. So this is just a movie showing how the test is. You'll see it's very fast.
Okay, hold real still. Hold your breath.
It's moving in the arc, taking the Tomo pictures. Now it's going to swing back to center and do the 2D. So that's it. It's quick. I mean, for the patient, it feels the same as a regular mammogram. It's very fast. So when we're taking those pictures, in the United States, currently we have to do 2D plus 3D. So you get a 2D image followed by the Tomo image. So 2D plus the Tomos. Those Tomo images, the original images are projection images. So these are the ones that are taken in the arc. Do you see how it kind of plays like it's going in an arc over the breast? Those can be helpful, but usually we never look at those. Those are reformatted into the Tomo slices. So these are 1 millimeter slices through the breast. And you can see the beauty of this is that it's going to uncover stuff. It's going to get rid of summation, artifact, and things like that. Oops. There we go. So the biggest advantage of tomosynthesis is the reduction in recalls. So the studies have shown that there's many studies now. So 30 to 40% reduction in recalls. That's a lot because as I showed you guys today, there's a lot of stuff that, is it summation or is it a real finding? And by doing those arced images, you get rid of a lot of summation artifact. So the recall rate definitely declines with tomosynthesis. So for this patient, for example, she has this area that should be recalled, but here's her Tomo. And as we go through, you can see that it's just normal, nice, respectful, wispy breast tissue. So there's no need to recall her. So that's a huge advantage of tomosynthesis. Now, does the recall rate change by density, though? Because that's really why we're here. Does it help women with dense breast tissue? So interesting. So these are recall rates for when you use tomosynthesis with the 2D. This is if you just did the 2D mammogram. by REDS density categories. And you can see that the recall rate reduction was actually best for women with extremely dense breast tissue. So it does seem like for women with very dense tissue, at least it reduces their recall rate. Does it find more cancers? That's a big question. So let me just show you a couple of other tomosynthesis cases, and I'm sorry, they're very dark up here. If you want, I'm happy to show you them on the screen later. So this woman was recalled from screening for, it looked like there might be a mass in the superior aspect of her right breast. And here's her tomo. Sorry, I'll go down. So just watch the movie. Oh. So right in here, there's a spiculated mass. Right in there. I can play it again for you. Do you go through? There you go. Do you see the spiculated mass right there? Here's a close-up of her. This is a close-up of the slice from her tomo. And you can see a spiculated mass here. And I'm sorry, it's dark. But the other fine thing that you see actually is that there's a second cancer there and a third cancer down there. So she has two other small spiculated masses. There's no way that we would have seen those at all on the 2D. So cancers become much more evident on tomosynthesis. Here's another one I'll just show you. So here's her mammogram. It's busy, but it looks pretty good. And we'll just go through the tomo. Okay, do you see it? Yeah, it's like big spiculated mass in there, and the mammogram doesn't look that bad. So yes, I tell you, when you get tomo and you start hearing people gasp in the reading room, you know, they just be reading, what, really? And you look at the 2D again, and how could that be in that breast and I can't see it? So that uncovering those cancers, it really does help you diagnose more cancers. Just one more. This is as normal a mammogram as I would call. And there we go. Yeah, so she's got 1, 2, 3, 4 areas of architectural distortion. This was a huge area of invasive lobular carcinoma. I can't see it on her 2D whatsoever. So I think this is going to be especially good for invasive lobular, sort of uncovering that distortion, those straight lines. I think distortion is especially well displayed on tomosynthesis. So what the literature shows is that like the recall reduction, sensitivity is also improved by about 30%. So finding 30% more cancers, that's a lot more cancers on tomosynthesis. So if, for example, this study by Skane, and there've been a couple more since this, 30% increase in cancer detection, and specifically 40% increase in invasive cancers. I mean, I don't know about you, but I don't feel like I need to find any more DCIS, okay? We're pretty good at calcs, that's okay. Invasive cancers, I want to find those earlier because those are the ones that can metastasize, go to their lymph nodes. I want to find them when they're a stage 1, not a 2 or a 3. So these are potentially clinically important cancers. Now, does this vary by density? Because again, that's why we're here. There's really not very much in the literature about this. This is the only study that I could find looking at density and the sensitivity of tomo. So there are improvements for fatty and scattered and for heterogeneous and dense, but I wish they would have done it by the 4 categories, not sort of lumping the 2 groups together. The improvement in sensitivity is actually a little bit lower for heterogeneous and dense than it is for scattered and fatty. Okay, but this is my personal experience. This is a 2D of a woman with very dense tissue, and this is her tomo slice. I mean, they look the same. So in order to get improved performance from your tomo, you've got to be uncovering stuff, which means that really you want to have heterogeneous. You've got to have some fat in there to get the tissue contrast. So if you have a clump of tissue and you're doing these arced views, it's just going to be a clump of tissue. If it's more heterogeneous with some fat in there, then you're going to be able to uncover things and see them better. So I would love to see more data on this topic, but my personal experience is women with very, very dense tissue, I tell them not to bother with the tomo. They're getting more radiation, and they're not going to get much bang for their buck. So the problems with Tomo, it is a higher radiation dose, and we can do a synthesized 2D image now. It's called C-View, but and GE is also now FDA approved in the US, and they also have a similar synthesized mammogram. So now we can do just the Tomo views and make a synthetic 2D image to compare to, rather than doing the 2D plus the 3D. That alone will bring our doses down to about the level of a regular mammogram. It does take longer to read these, so if you have a stack of Tomos, it's definitely going to take you longer. In the United States, we don't get reimbursed for Tomo. Almost nobody pays us for these. Women self-pay, so we charge $80, and about 40% of our patients pay. We still get billed their insurance or Medicare for the 2D regular mammogram. They have to pay an additional $80 for the Tomo. But a lot of women want it and ask for it. So that's Tomo. Okay, so let's talk about screening ultrasound now. So typically screening ultrasound is bilateral ultrasound of both breasts. It could be performed by a radiologist or a technologist. And there are also now automated ultrasound machines where they put sort of this, it's like a rubber drape kind of thing over the patient with some gel, and it takes a 3D acquisition. And it's kind of cool. You can look at it in coronal, you can look at it in sagittal, axial, different ways. The data for the automated programs has not been as good as handheld up to now. However, I understand there's going to be some things presented at RSNA that show improved performance. So it may end up being as good as radiologist handheld ultrasound at some point. So we started with screening ultrasound with the Akron 6666 trial, which was high-risk women. Now the high risk, a lot of those women were really just moderate risk. They'd like had a mastectomy in 1972 or something, had no family history, things like that. Now, so those women, this was Wendy Berg's study, and they found out of these 2,600 women, 111 cancers. So after their mammogram was done, and maybe the mammogram found cancer or not, but the ultrasound found an additional 5.3 cancers per 1,000 in year 1 and 3.7 in year 2 and 3. So if you think about screening mammography finds about 5 cancers per 1,000, and you're adding another 3 to 5, that's significant. That's a lot more cancers. So I think that this is a reasonable option. Now somebody's going to say, but those are high-risk women. And that's a good point. Are we going to get those numbers from women who are dense but not otherwise high risk? So what do we know about that? Well, remember I told you Connecticut was the first state, and that was the one where they had the money. Like if the doctor asked for a screening ultrasound, the insurance had to pay for it. So they do a boatload of screening ultrasound in Connecticut. So there are 2 studies that have been published from there, from out in practices. So one of these, the Weigert study is a private practice group, and Hooley is the Yale group. So, but both had very similar results. Basically, they found 3 cancers per 1,000 in addition to mammography. So 3 per 1,000, that's still quite good at an otherwise average risk. The problem is this, and this is why US radiologists hate screening ultrasound, is that 5 to 7% of women who have a screening ultrasound are going to get a biopsy. That's a lot. Because think about mammography, it's 1 to 2%. It's a lot more women are going to get a biopsy. And when you do a biopsy, really low PPV. Mammography and ultrasound, a regular diagnostic service, 25 to 40% should be cancer, not 6 or 7%. That's really low. And they also had a lot of BI-RADS 3s. So I do offer screening ultrasound in my practice because I feel that, if a woman is very dense, I know mammography isn't that good. I mean, we're going to miss cancers in these ladies. So I do offer it. I don't go out and publicize it, you better have a screening ultrasound, but if they request it, I will do it for them. Now, when I go in, I talk to the patient and I say, okay, before I start, we're just going to talk about this for a minute. So what I need you to know is that you have about a 5% chance that I'm going to be telling you that you need a biopsy, and it's probably going to be benign. Maybe it's a cancer. I'm going to think it's a cancer, but it's probably going to be benign. And if you're okay with that, we'll go ahead. And of the patients that I've talked with, I have had a couple of patients that are like, wait, say that again? I could have a biopsy? I don't think I want to do that. And so they're fine and they're gone. But I want them to know that ahead of time. Most of the patients are worried, and that's why they've chosen to have the screening ultrasound. Like Tomo, our insurance carriers are iffy on the screening thing. So our billing, I will tell you, a lot of places offer screening ultrasound but bill it as a regular diagnostic ultrasound. I think that's playing with fire, and I don't want to get caught in any reimbursement fraud thing. Like, I don't want you to see my picture on the paper. That's not good. So we have women self-pay. If they want screening ultrasound, there's a $100 charge. I don't bill insurance. That's just what I do. So they self-pay. So like Tomo, they can choose. If they want to have additional imaging, we offer it to them, but that's their choice, really. So that's screening ultrasound. So screening ultrasound, it's a good test. It's not even close to a great test, but kind of it's what we have right now. We can't afford MRI, so that's why I offer it. But really what we'd like to do for these women with very dense tissue is a functional exam. Getting better anatomy of dense tissue, it's not going to really help us. I could look at that woman with really dense breasts with 0.1 millimeter resolution, but it's not going to help me. It's still just white. So the tissue contrast is low. So if we could do a functional test that looks at blood flow, mitochondrial activity, some other functional way, that seems like that would be a much better way to image these ladies. So there's this new technique, contrast-enhanced spectral mammography. We just got this installed at our place, but we've only done a few patients. So basically what you do is you inject iodinated contrast, same as for a CAT scan. Use a power injector. You wait for 2 minutes, and then you take your 4 views, or more if you need them for coverage. And during the exposure, it takes a low energy and a high energy exposure. So this first one is below the K edge of iodine. So that's going to be like your regular 2D mammogram that you'd get on any machine. This one is a high energy exposure. You're going to see the iodine and the breast tissue. You subtract those to get an iodine image. But the patient doesn't know. I mean, it's basically like the Tomo. It's like, bzz, bzz, okay, you're done. That's your picture. So it's not like it's a long exposure or anything.
How much contrast are you injecting?
Same as for a CT, yeah. So it's a good dose. So that is a risk. These are examples from the vendor. I do not have stock in the vendor, so take it or leave it. I don't really care. But like I said, I've only done a few patients back at home yet. So this is a woman who presented with nipple retraction. She's obviously got a spiculated mass in that breast. But she's got really dense tissue. All right. But here's her contrast enhanced. Wow, so much easier to read, right? So she's obviously got this enhancing spiculated mass, but she's got at least 3 other foci of invasion that we don't see whatsoever on her mammogram. So a functional test like this could end up being much better than our current 2D mammogram or ultrasound. Because this is a very new technology, the literature is very small, okay? So there's only a handful of studies in the literature. This study was 113 women that were recalled because of an abnormal mammogram. So they're already abnormal with an abnormal mammogram. In that study, there were 32 cancers. An extra cancer was detected on the contrast that was not seen on that 2D recall. The specificity was much, much better. The PPV for biopsy much higher. And so all of that, the specificity particularly increases the ROC to be much higher than the regular 2D mammograms. And interesting, you have to wonder, well, could this potentially be similar to MRI? I don't know. Small study, again, there's only 2 studies right now that compare the contrast enhanced and MRI. In this study, which is from Europe, 80 women with new breast cancer, so they're known cancers, underwent mammogram, contrast, and MRI. And you can see the numbers. Mammogram missed a fair number, all seen on contrast. 1 woman couldn't get an MRI. I don't know if she was allergic or wigged out or whatever, but MRI only saw 77 of the 79, which is kind of interesting. So a couple of, these are images from that Fallenberg study. So this woman, here's her mammogram. This is directly from the paper. And you kind of look, it's like, yeah, it looks like there's a mass. She's got really dense tissue though, right? I have no idea where that is on her CC view. That's her prior mammogram, sorry. But here's her contrast enhanced. It's like, well, I can see that. It's a big enhancing mass there. Here's her MRI, and you can see similarly it shows that no other findings on MRI. So that one was a true positive for both contrast and MRI. This was a false negative on MRI, which I found pretty interesting. So here's her 2D mammogram, her contrast, and you can see there's an enhancing mass in this upper outer quadrant of her left breast. On the MRI, so remember the contrast pictures are taken right after each other, right? And then you subtract the two. But as we all know in MRI, those patients breathe. I don't know why they breathe, but when they breathe in and out, there's going to be some motion artifact, right? So this patient, because of the breathing motion and the parenchymal enhancement, you can't see this invasive lobular carcinoma. So that was read as a negative. So that was a false negative for MRI. All right, so I've given you a lot of information here. So what might a possible screening strategy be then? Well, if a woman is high risk, it doesn't matter what density she is. She just needs an MRI. So she'll get a mammogram, she'll get an MRI, she's done. We don't really need to think about them anymore. Okay, but what if they're not high risk? Well, if they're fatty replaced, and we show that they're lower average risk for breast cancer using some risk assessment tool, then really they should just get a 2D mammogram, I think. Tomo can benefit them some, but I don't think the benefit is going to be as high. I have found some cancers on Tomo, lobular, of course, that you couldn't really see well on 2D. But also I put the annual in parentheses because in the United States, we still advocate very strongly for annual mammography for every woman. But really, I mean, really, they're fatty replaced, they're low to average risk. Can't we space those out? Or maybe if they're, in their 40s and they're fatty, they're low risk, can't we wait till they're 50 to start screening? I think we've got to start stratifying these women. Okay, what if they're scattered? Well, then probably they need tomosynthesis, and we can argue based on risk, maybe if they're lower risk, they could do it every other year. Heterogeneous, right now, what we're recommending is the Tomo and plus or minus ultrasound. One of my friends, Jay Baker at Duke, when I said, well, yeah, I offer screening ultrasound, he said, what, don't you have tomosynthesis? I was like, of course I have Tomo, Jay, but I don't think that they're all the same cancers. You have that woman with really dense tissue. I think that she still could benefit from screening ultrasound. So I think at least some of these might be the same, but I think at least some of them are also different. So adding both may be helpful. And especially the extremely dense. Now for them, what I usually recommend is just the 2D. Don't get the Tomo. Don't spend the $80 on that. If you're going to spend more money, get the ultrasound because the Tomo may not add much for you. So that's sort of my idea of doing screening based on density at this point. But in the future, I think we really have to think about ways that we can go to functional imaging, like contrast or gamma imaging. The reason that we don't do gamma imaging right now is because we have to give them 20 millicuries of sestamib, which is a big body dose. To do that every year is a lot of radiation. But with dual-headed gamma cameras, they're getting that down to 8 millicuries now. If we could get that down to 4, then the total body dose is actually very reasonable. So that might be another alternative functional imaging test that we could do for women with dense tissue. But I think we've got to think about ways we can get away from anatomic imaging in these women. Likewise for extremely dense, we got to think about functional imaging. All right, so I'm just going to wrap it up here. So breast density has become a very political issue in the United States. A lot of this is put forth by advocates and this grassroots sort of group that's pushed this through. But it's true, dense tissue is a problem. It masks cancers and they're higher risk for getting them. So they got the double whammy, more cancers, and I can't find them as well. MRI is a great test, way too expensive to use just for the average woman, at least as we do it right now. Tomosynthesis decreases recall by 30 to 40%, increases cancer detection by 30 to 40%. It is a really good test. Not sure that it's going to be so great for women who are really, really dense, though. For those women, screening ultrasound may be the best alternative because, like Tomo, we find 30% more cancers. So that might be our best option right now for women with very dense tissue. But functional imaging really makes much more sense to me as far as our long-term options for managing these women. All right, well, thank you.
I've heard anecdotally that women of certain ethnicities have on average higher density breasts. Is that true? And if it is true, then does that mean that they're at an increased risk of developing breast cancer?
So the question is that some women have denser breast tissue based on ethnicity, and does that increase their cancer risk? So that's a really good question, because a lot of people say, but what about Asian women?
Yeah.
They have very dense tissue and yet they're at lower risk for developing breast cancer. Well, I think that's a complicated story, because for women who are Caucasian, Black, and Hispanic, when you adjust for BMI, it's all the same risk. So you have to adjust for BMI, right? Because there's differences in BMIs based on ethnicity and things too. Asian women, when you adjust for BMI, it comes closer to Caucasian spectrum of risk with density, but not exactly the same. But interestingly though, I was fortunate to go to Korea a couple of years ago, and if you look at their incidence of breast cancer, it's almost all premenopausal. The women they want to screen are in their 40s, because by the time they're 55, they've either had breast cancer or they don't. But the curve is shifting. So every year that curve shifts a little bit. Why? Because they're becoming westernized. So the risk is increasing and peaking later. So there's got to be something environmental or something there. So I think it is just more complicated, and I don't have the answer, but when I go to Sweden and pick up my Nobel Prize, you can come with me.
Okay, I'll do that.
Other questions?
So you talked about people with denser breast having increased risk of breast cancer. Is it that the actual risk is higher, or we just don't see the cancer early on because the breast is so dense?
That's a good question. So is it because of masking?
Yeah.
Is it a sort of a not right assessment? So interesting, if you have to take that into account when you design your study. So if you look at patients on day one, as far as their cancer risk, that actually downplays the risk of cancer for women with dense tissue, right? Because you're going to find less. Or you can look at them at least 4 years later, because by then those cancers that you missed on screening at that original time point should have sort of washed in by then. They should have become clinically relevant by then. So you have to look at it either early or late in your study design, but you have to kind of take that into account, because masking could falsely elevate that later. Yes, it's a good point. Yeah. But one thing I want to mention, which I didn't earlier, is how we talk to women about their risk. Because that Are You Dense group, they read our literature and said, well, I'm high risk because I have dense tissue. And I showed you they're 4-fold increased risk. That sounds pretty high risk. But that's if you take the really dense woman compared to the fatty woman. I mean, most of us are somewhere in the middle. So it's, if you look at it by BI-RADS categories, it's like 10, 40, 40, 10. So we're comparing our 10% to our 10%. So the average risk woman, let's say the average woman in our neighborhood, that's what she wants to know. What does this mean to me? That woman who's extremely dense is about twice as likely as sort of the average woman for getting breast cancer. So that makes it a moderate risk factor, not high risk. So they don't all need MRI and all of that. So I think that's a good way to kind of communicate that with our patients. Yeah, you're not high risk, you're at higher risk.
Do the patients get a copy of the mammogram? Because I remember at the beginning of the first couple of slides, it said your risk is as if you're talking to the patient, and the report goes to the requesting physician, obviously. But does the patient get a copy of the report so that they know how dense their breast is?
So it is not in their letter. So the FDA requires that we send a letter, it's a generic letter, based on the BI-RADS categories essentially, saying, your mammogram's normal or your recall or whatever. In those FDA required letters is where we put that verbiage. And so if the woman is heterogeneous or dense, they get that blurb. Yeah. But they don't know specifically, am I extremely dense or heterogeneous, unless they get the report, which they don't get. Yeah.
So are you currently using a measuring tool to gauge density, because you were talking about measuring tools, or are you still eyeballing it?
So we use the Volpara, the automated density, because it's just much more reproducible. We know that we radiologists are inconsistent with ourselves and each other. So we use the automated program. However, that said, Sometimes you look at the Volpara and it says it's extremely dense and she's fatty replaced. I'm going to use my visual assessment if it really overrides the Volpara.
It's more an opinion, because I guess it's so early in the research, but I was a bit intrigued by the contrast enhanced mammography.
Mm-hmm.
The study that you had seemed like it was almost on par with MR. Can you see that because it'd be a much cheaper alternative, that if this does live up to the billing, that it could totally change the way that we do things, as far as, like you laid out an algorithm,
Mm-hmm.
like could it theoretically knock out all those other things like Tomo and doing screening ultrasound if it is that effective?
Well, I think that's a very good question. I think that the issue as far as would something like contrast enhanced replace Tomo or screening ultrasound, my concern with the contrast is, well, first of all, we have to start an IV, so that adds cost and time. And for screening, you really would like a test where they're in and out in 10 or 15 minutes, so it's going to prolong that. And then we're giving them contrast. And as minimal the risk it is risk, right? So women are going to have nausea, vomiting, great. They're going to have, but could they have a significant side effect like an allergic reaction? Yeah. So we need to really make sure that this is an important indicated test before we give them something that's more invasive. But really, I think we have to do something like this, especially for those women who are really dense. I don't think we're doing them justice by telling them they have a normal mammogram. Yeah, so that's my opinion. But it could end up being gamma. We'll see.
I just have a question about outcome with these new sort of using screening, ultrasound, or even Tomo, whether it actually changes the natural history of the disease, picking up these other things earlier on, or is it lead time bias?
Well, that's a question. So the question is, would adding another test like tomosynthesis or screening ultrasound or even the contrast enhanced change the natural history of the disease, or are we just finding it earlier with lead time bias? I don't know. The only test that we know has a proven benefit as far as mortality is mammography, and that's film screen mammography. We don't even have that for digital, and it's hard to do those trials, right? Like you're going to randomize somebody to not get a digital mammogram or not. Etta Pisano, though, is trying to organize the TMIST, which is the tomosynthesis imaging trial, similar to DMIST. And actually, the trial is opened and sponsored by the Canadian government. That Toronto and Vancouver are recruiting patients beginning, I think, next week. And also MUSC down in South Carolina, where Dr. Pisano works. And their endpoint is not just cancer detection, but they want to follow these women long term to see if there is, what their mortality is long term. Is it lower than, you're not randomizing, so you can't compare to randomized women, but you could at least look to baseline. So hopefully they could get some information out of that. But it is a good question. You want to find the ones before they metastasize. I mean, we know from lots of data that smaller is better. I mean, we know that. So, but how small, I don't know. Some cancers are going to metastasize early.